So today we're going to talk about inflammatory bowel disease that's also known as IBD. Before we get into that, a little bit of review or background information, if you will, on the colon. So when we look at the colon, it's not essential for survival, but its functions contribute significantly to the overall well-being of the individual. When we take the colon and divide it in half, it can be functionally divided right through the center of the transverse colon into a right colon and a left colon. The right colon, which is going to include the cecum and the ascending colon, plays a major role in water and electrolyte absorption, as well as fermentation of undigested sugars via the normal flora in the colon. The right colon has a large luminal diameter and thin walls. Now, because the contents are basically liquid in this area, it is very rare to have an obstruction on the right side of the colon. It's typically going to be a late event, moving up more commonly into the transverse colon or moving into the left colon. Now, if bleeding occurs in the right colon, it's usually going to be occult. They may have fatigue, weakness, and also severe anemia. Those are the major complications with it, or complaints, if you will, not complications, sorry. The left colon, which includes the descending colon, the sigmoid colon, and the rectum, this is mainly involved in storage and evacuation of the stool. Now on this side, the luminal diameter is smaller than the right side, and the feces are semi-solid at this point. If bleeding develops on this side, it's going to be more frank or red, and is typically seen in the stool. So inflammatory bowel disease, or IBD, is a group of diseases that include Crohn's disease and ulcerative colitis. Now, these are relapsing and remitting conditions that are characterized by chronic inflammation at various sites in the GI tract, and it results in diarrhea and abdominal pain. Now, the inflammation that develops is due to cell-mediated immune responses in the GI mucosa. As for etiologies, there's no specific environmental, dietary, or infectious causes that have been identified. So the etiology is still considered to be unknown, but it's considered to be an autoimmune disease. On average, about 10% of all colitis cases are of unknown causes. There's been some interesting evidence that says that cigarette smoking may increase the risk of Crohn's disease, and this does tend to run in families, so we're looking at possible genetic tendencies or predisposition. Now, both Crohn's disease and ulcerative colitis are very similar, but they can be distinguished in most cases. Crohn's disease. This condition is also known as regional enteritis, granulomatous ileitis, as well as ileocolitis. Crohn's disease is a chronic transmural inflammatory disease that usually affects the distal ileum and the proximal colon, but it may occur in any part of the GI tract. Now, with Crohn's disease, perianal fistulas and/or abscesses can commonly develop with this presentation. And the patient may not have a lot of GI symptomatology, but they may be dealing with this, so this would definitely be a consideration. Also, we'd have to consider Crohn's disease as a differential consideration in patients that have unexplained polyarthritis, fevers, as well as chronic anemias, especially in light of the fact if the patient has a family history of this disease. Please review this illustration of a perianal fistula. Symptoms and signs include diarrhea that's typically non-bloody, anorexia, weight loss, abdominal pain, possible internal or external rectal fistulas and/or anal abscesses, fever, and arthritis. Now again, the diarrhea is typically non-bloody. The abdominal pain is going to be mainly in the right lower quadrant, but there's been documented cases of it being in the left lower quadrant as well. On examination, there may be abdominal tenderness with the presence of a palpable mass. The rectal fistulas or anal abscesses can develop on average in about a quarter to a third of patients. The arthritis presentation can include polyarthritises, as well as sacroiliitis and ankylosing spondylitis. Now, the symptoms are usually intermittent, so these patients will report periods of remission, then periods of exacerbation. Now, as for this disease onset and progression, typically this will start between the ages of 15 and 30 with the initial development of cryptitis. If you'll recall, intestinal crypts are tubular structures that are composed of cells, and they protrude from the inner lining of the intestines and into the walls of the intestines. Well, these crypts contain the cells that give rise to all the other cells that move out of the crypts and eventually line the inner lining of the intestines, or the mucosa. So the inflammation of these crypts are known as cryptitis. So we have the initial development of cryptitis between the ages of 15 and 30. Then, as the inflammation continues, we will see it progressing to initial ulcerations, edema, then there will be deepening of the ulcerations, which will lead to lymphedema and eventual thickening of the bowel walls and the mesentery, where we have subsequent fibrosis begin to develop. Now, this fibrosis is going to create segments of the diseased bowel that are sharply demarcated from adjacent normal bowel tissue. Now, these segments or these sections of the diseased bowel that are sharply demarcated from the adjacent normal tissue, they're identified or named skip lesions, also known as discontinuous lesions. So this gives rise to the name of regional enteritis for Crohn's disease as an AKA. 35% of the cases of Crohn's involve the ileum only, hence ileitis. 45% of Crohn's disease cases involve the ileum and the colon, hence the name ileocolitis. 20% of Crohn's disease cases involve the colon alone, linking to the name of granulomatous colitis. The rectum is spared with this disease. The rectum is not involved with Crohn's disease. Please note there's an increased risk of cancer developing in the segments that are involved in those areas where those skip lesions are. Over the course of the disease, on average, 60 to 70% of patients will require surgery, and half of those patients will require more than one surgery. Here's an example of Crohn's skip lesions. This particular form would be identified as being a primarily stenotic or obstructing form of Crohn's disease. Here's an example of Crohn's skip lesions on colonoscopy. I've specifically circled one of the lesions on the left illustration for your view. Now, there are three forms or classifications of Crohn's disease, and this is identified as Vienna classification of Crohn's disease. They are primarily inflammatory, primarily stenotic or obstructing, and primarily penetrating or fistulizing. So treatment of Crohn's disease is dependent upon its location, its severity, the presence of complications, and the response to medications. The treatment goal is to reduce the inflammation that triggers the patient's symptoms. So treatments are going to focus in on relieving the symptoms and producing long-term remission. Treatment typically involves a combination of medication and/or surgery. Ulcerative colitis, abbreviated as UC. Ulcerative colitis is a chronic inflammatory and ulcerative disease that arises in the mucosa and the submucosa of the colon. It is most often characterized by the presence of bloody diarrhea. There's a couple of research articles that have indicated that smoking may appear to decrease the risk of ulcerative colitis, and it may increase the risk of Crohn's. The long-term risk of colon cancer is high in these patients. So the symptoms and signs of ulcerative colitis include the presence of bloody diarrhea. It's of varied intensity and duration, and then it's interspersed with asymptomatic intervals. So patients typically report that the attacks begin insidiously. They start having an increased urgency to defecate. They'll typically experience mild lower abdominal cramps, and then there's the presence of blood and mucus in the stools. Now, symptoms include fatigue, unintentional weight loss, anorexia, during exacerbations or episodes, fecal urgency, tenesmus, nausea. Please note, arthritis is a major extraintestinal symptom. Now, with ulcerative colitis, foods such as raw fruits and vegetables or highly seasoned foods may trigger a flare-up, as well as in some people, milk products will. The diagnosis of this condition is usually based on their history, along with the presence of the unexplained arthritises, polyarthritises, along with the possible history of things like hepatitis, cirrhosis, osteoporosis, skin rashes. Again, we're looking at extraintestinal symptomatology. Now, the disease onset and progression, again, it can occur at any age, but it most often begins between the ages of 15 and 30. It tends to run in families. It affects either sex. And ulcerative colitis begins in the rectum. And if it's localized when it's diagnosed, it's often identified as ulcerative proctitis. So ulcerative colitis begins in the rectum, and then it moves and progresses proximally, involving all the tissue as it goes, and it may eventually involve the entire colon. Now, this condition is going to produce large mucosal ulcers, and we're going to have large amount of purulent exudate from this. Anywhere from 25 to 40% of ulcerative colitis patients must eventually have part of their colon removed, and the cancer risk with this condition is going to increase as the area of colon involvement increases as well. So here's an illustration reflecting the ulcers that can develop within ulcerative colitis and how it's moving proximally, starting at the rectum and then moving up through the left side of the colon into the descending colon. So here are endoscopic photos. On the left side is an example of a healthy colon. On the right side is an example of a colon with ulcerative colitis. Here's another example of an ulcerative colitis presentation. Here's another example of an ulcerative colitis presentation, and here you can see the metaplastic changes occurring that could contribute to stenotic or obstructing presentations with this condition. Now, when we're looking at Crohn's disease versus ulcerative colitis, remember at the beginning of the lecture I mentioned in most cases you can distinguish between the two conditions. So when we look at Crohn's disease, we're going to see that the small bowel is involved with Crohn's disease in 80% of the cases. Ulcerative colitis starts in the large bowel, the colon. With Crohn's disease, the rectum is spared. With ulcerative colitis, the rectum is involved, and that's typically where it starts. In Crohn's disease, gross rectal bleeding, extremely rare. In ulcerative colitis, it's common to have gross rectal bleeding. With Crohn's disease, there can be the presence of anal fistulas and abscesses, very common. With ulcerative colitis, no anal fistulas and no abscesses. With Crohn's disease, we have the skip lesions where we have those areas of fibrosis and scarring surrounded with normal tissue. With ulcerative colitis, the whole bowel is infected. Not infected, affected. The whole bowel is involved, it's affected.